Read that item into the record.
Yes, and Chair Hart, members of the board, prior to moving on to item number 1, just for organization's sake, can we please get a motion on the withdrawal of departmental item number 2? This is previously read into the record, but this is from Public Works, Board of Directors, Flood Control, and Water Conservation District and General Services. It was a hearing to consider recommendations regarding a resolution of necessity for a temporary construction easement for the Lower Mission Creek, APN 037-245-017, number 3784, owned by Reginald E. Drew, Jr., 1st District. And this item, we received a withdrawal memo this morning from the department requesting to withdraw it from today's agenda.
Is there a motion to withdraw this item from the agenda?
So moved.
Motion's been made
Second.
and seconded. Any discussion? Madam Clerk, could you please call the roll?
Mr. Williams?
Aye.
Ms. Hartman?
Aye.
Mr. Adam?
Aye.
Mr. Lavanino?
Aye.
Chair Hart?
Aye.
Motion passes unanimously.
Thank you. And that brings us to item number 1. Would you please read that item into the record?
Chair Hart, members of the board, departmental item number 1 is from the County Executive Office. It is a hearing to consider recommendations regarding a coronavirus disease 2019 COVID-19 update.
Welcome, Dr. Del Reynoso.
Good morning, Chair, members of the board. Today's briefing topics will include the usual Santa Barbara County COVID-19 data and an in-depth look at the blueprint for a safer economy, going over our anticipated status, as well as reiterating our recent health officer order amendment, introducing to you in a little bit more detail the health equity metrics, as well as having an in-depth briefing on the Latinx and Indigenous Migrant COVID-19 Response Task Force, as per your request in a previous meeting. And we will end with school waivers. COVID-19 by the numbers in Santa Barbara County, we have cumulative case count of 9,319, cumulative recovered cases 9,082, and we have 122 active cases. This means that there are still 122 infectious cases in our community. We have 23 currently hospitalized, and a total of 115 deaths, which makes that death rate at 1.2%. Over the past 15 days, with the 7-day rolling sum of new cases by areas, for the most part, we are continuing to see decreases in the majority of our areas. We are seeing 4 upticks in primarily the North County. We are seeing an increase in Santa Maria, in Orchid, and in the unincorporated North County. South County, we are seeing an uptick in the Montecito Carpinteria area. Over the past,
Can we put that a little bit in context? We had 2 last
Correct.
week, so I only know this because in elections you have to deal with a lot of
Right.
statistical work. When you have an N that's almost 0, then you're going to have large fluctuations. And so people have looked at the numbers in South County unincorporated all summer long, because either to draw their own conclusions of a 200% drop or a 100% rise. Well, when the N has fluctuated between 2 and 15, you're going to always have large rises or large falls because the sample size is so small.
that is true, but I didn't want to be not transparent by stating that there was an increase. And with the hospitalization over the past 2 weeks, we see a range of census from 18 to 26, but overall beginning number to end number with no change. Per Supervisor Adams' request, I've included 2 slides. This is the daily hospitalized cases since April 29th through October 3rd. And I want to point out that the bulk of our high census was in the mid 80s within the early part of the summer, in the July and early part of August. And we are seeing a decrease in hospital census overall. This is the second new graph. This describes the COVID deaths by week of death. So we have the Rust line describing the cumulative deaths due to COVID in our county, and that stands at, I just shared, 115. And with the blue bar graphs below, showing the number of deaths by the week that it occurred. And so we did see in also midsummer in July 19th, 12 deaths, and early part of August, 11 deaths. Those are the single highest weeks with deaths.
Mr. Chair.
Supervisor Adam.
Okay, Dr. Del Reynoso, I'm going to be bipolar with you. I love your chart on page 6. I think that's a fantastic representation of how we've gone over the curve. And I don't know if we flattened the curve or the curve took care of itself, but it is what it is, and there it is graphically represented in front of us. And the only real problem I have is we started about a month late, and maybe there wasn't any cases. Is April 29th the first case date?
You know, Supervisor Adam, I am not sure about that. I know that our first case was March 15th, but I don't recall when our first hospitalized case may be, and that's something that I can check with our EPI team.
Well, I'm going to bet that was probably a hospitalization, because at that time I don't think we were doing much testing, and speculative testing. And I think that the way people came to our attention was they were admitted. And so that may have been, there may have been a few cases before that, so the curve isn't exactly complete, but it's substantially complete, and I thank you for that. That's a great representation of why we should open up. You've ridden over the hard part. The second one, I'm not a big fan of, because first of all, I didn't ask for the continuous death count, and I think that continuous counts are a bad metric, because we don't keep track of anything in continuous counts except COVID. And so when this line, you're going to constantly have to be adjusting the scale of this graph, which is just going to make the bottom set of data that I wanted flatter and flatter and flatter over time if you keep that line on there for the cumulative deaths. And we don't keep track of cumulative deaths from heart disease or cumulative deaths from anything else. And so I don't think we should be looking at it that way. And for these graphs, I would request that you keep them clean and keep them on a representation on a scale. See, you could make your graph if you had that thing on a 20 scale, your lines on the bottom would be much more pronounced, and you could see trends, and you'd have two tops in your line instead of having them minimized. So and to that degree, I like it when it minimizes deaths, but I don't think, if we're trying to display information, I don't think that's useful to have one parameter on there that nobody ever keeps track of in any other context, so that it flattens the other data that we're trying to get to beyond usable recognition.
Supervisor Adam, through the chair, I can certainly do that, given that we do track the cumulative death on the first slide that I show. So I can definitely take off the rust color graph depicting cumulative deaths.
Yeah, and then change the scale for next week's
Yes.
presentation to a 20.
Right.
And then you're really going to see that those peaks and valleys pop. Thank you.
Maybe the best way to do it is to have two different charts, because when you rely on the first chart with the cumulative cases and the cumulative deaths, the same problem that Supervisor Adam described happens in that instance. So thank you for that, Supervisor Adam. Dr. Del Reynoso?
Because all of the information's in the tails. That big open part in the middle just doesn't mean anything.
Blueprint for a safer economy. Last week, we issued an amendment, Health Officer Order 2020-12.10, to highlight that outdoor public playgrounds are permissible with guidance. We further clarified higher education as to have the capacity to be opened indoors at 25 capacity or 100 people, whichever is less. Bars, breweries, brew pubs, and distilleries, if serving meals, to follow the restaurant sector limits, as well as wineries and tasting rooms being allowed indoors if serving meals to restaurant sector limits. And I want to pause and really thank Assistant CEO Nancy Anderson for working with the Public Health Department in reaching out to the sectors and making sure that the sectors understand the parameters of opening indoors. The blueprint for a safer economy, as of October 6th, we will be looking at adjusted case rates, something that you have seen, test positivity, also have seen. What is new that I've alluded to earlier is the health equity metric that will be effective today. I believe that the governor will be releasing the numbers at noon, as well as the targeted investment plan, which all counties will have to apply or fill out by the 13th. So this is a familiar table that you have seen, with the last row being the newest, and that is the lowest healthy places index quartile test positivity rate. So in addition to the parameters for us to move to tier 3, where disease is moderate, we will have to also make sure that our bottom quartile does not exceed 5.25 in the test positivity rate. And I will be going through that in more detail with these next few slides. Health equity metric, the goal is to reduce and possibly eliminate disparities in the levels of COVID-19 transmission among county residents. It is also to improve all county COVID-19 data reporting. The state has noted that about 33% of the demographics are missing as counties report them. So there is an increased effort to improve the reporting on race and ethnicity data as it pertains to COVID-19 cases. And CDPH will be posting county-level data for race, ethnicity for tests, cases, and deaths. And I'd like to share that our team has been working on providing this data. And for the next Tuesday's presentation, I will be going over the demographics for our county with regards to cases, hospitalization, and deaths since March 15th. The goal of the health equity metric is also to improve testing positivity rates for the most disadvantaged communities. It will not be used to move counties back to a more restrictive tier, but it could have an impact on us moving to the less restrictive tier. And the point is to close disparities within all counties. And by that, the counties will be required, as I alluded to in the earlier slide, to submit a plan for how we spend our CDC funding on underserved communities in our county. So counties are assessed weekly basis on Tuesdays. The county must have been in the current tier for a minimum of 3 weeks. A county must meet criteria for the less restrictive tier for prior 2 consecutive weeks. This is with regards to us moving to the orange tier. A county larger than 106,000 in population, that we qualify, must meet the health equity metric for the same time period. And again, the targeted investment plan, my department will need to file by the 13th. While we can move to a less restrictive tier towards the orange as our goal, we can be moved back to a more restrictive tier where we started, the purple tier. So the county's adjusted case rate or test positivity has fallen within a more restrictive tier for 2 consecutive weekly periods. State and local health officials will work together on an ongoing basis to assess, and when moving to a more restrictive tier, counties will have 3 days to implement any sector changes or closures unless extreme circumstances merit immediate action. So just wanted to remind your board that we can move forward and we can move backwards. I anticipate that we, at noon, these are the numbers that will be announced for us. Our adjusted case rate is 5.8, still keeping us in the red tier. Our new cases per day per 100,000 unadjusted is 6.4. Positivity rate will be listed as 3.3, and the new health equity metric at 6.7. And this is for the data ending on September 26th. The case rate, as in graphic form, we call this our rainbow chart. Our case rate at 5.8. The increase in rate signifies that there are more cases being identified for our set population of 456,373. Testing positivity on this graph, 3.3. The decreasing testing positivity for the last 4 weeks means that although there have been more positive cases identified, a much larger number of COVID PCR tests were performed in the current rating period compared to the previous ones. So for this rating period, we see a slight increase in test positivity, even though the number of tests performed is higher than the state median. So what that means is that we are seeing a slight uptick in the spread of COVID-19 in our county. So we performed for this rating period 262 average daily. The state median average test is 216. So our adjusted factor was or is 0.91. So the raw number, 6.4, because of the quantity of tests, we were adjusted downward to 5.8.
Mr. Chair,
Supervisor Adam.
Dr. Del Reynoso, can you explain to me the difference in the curves on the graphs between that page? I don't know what page we're on right there. That was on the screen last, but that and page 6 of hospitalizations, because they're inverted. I don't understand how that could possibly be.
So earlier in the pandemic, when we had testing positivity, fairly limited capacity, and those were restricted to symptomatics. Earlier in the pandemic, we also saw that when people tested positive, there was also a quick turnaround time in which they were hospitalized. Many of those who were hospitalized were tested in the hospital as well. As the pandemic has progressed, we're seeing there is a lot of difference in the people, the age groups getting tested and getting diagnosed as a positive case, so that is reflected in this. And the adjustment is only that what you see in the percentage is really accounting for the numbers that we've been tracking within this framework.
Okay, so what that graph reflects is our moving testing protocols over time, where we were testing only symptomatic people, and then we started testing everybody that wanted to present, and then we started testing only symptomatic people again, and that coincides with those two rises, two peaks.
Right, and
Was the symptomatic people that we were testing, is that correct?
that is correct, but also the testing positivity percentages are dependent on the denominator, is dependent on the volume of being tested.
Well, right, but it also depends highly on what you're cherry picking your test subjects if you're only testing symptomatic people.
So early in the pandemic, there was nationally a shortage of test capacity, correct? And so we were following CDC and CDPH guidelines in prioritizing those who needed to be tested.
Right, and then there was a time in the middle where that graph has a sag in it between the first peak and the second peak, where we were testing everybody who presented. Isn't that correct?
Correct.
And then we went back to testing people who were positive or exhibited symptoms. And that coincides with the second peak. And we're still doing that to this day. Is that right?
So with the testing capacity, so the foundation of being able to box in this disease is widespread testing in the community so that you can identify cases and isolate or quarantine as needed. So this graph
Excuse me, that's not responsive to my question.
No, but if you let me finish, I would.
Well,
So what I'm saying is that
I'd rather
as we
just get the answer to
increase,
my question instead of your speech.
Mr. Chair,
Let's,
I understand
I
there's...
don't know if we're adding here. Let's,
I understand there's passionate feelings here, and I
No, look, I'm trying
appreciate
to
Supervisor Adam
establish a
asking
fact.
questions, but interrupting staff is just not an appropriate way to do this.
Negative,
Supervisor-
negative, Supervisor.
Dr. Del Reynoso
There's a
is-
longstanding tradition of doing exactly that.
okay, Supervisor Adams, Supervisor Williams, Dr. Del Reynoso is going to answer the question.
could you please repeat your question?
Are we testing symptomatic people at this point or not?
We are testing everyone who needs to be tested and wants to be tested, whether they are symptomatic or asymptomatic.
So you're testing, I'm trying to determine, how do we find people for testing?
We find people for testing based on their initiation of wanting to be tested. So in the community, an individual decides that they need to be tested for whether it be work, whether it be school, or whether it be a personal desire to know their status. In the hospital, before a procedure, before surgery, people are tested. And as
Okay.
and as a matter of
Go ahead.
fact, in our community testing, the majority of people who come to our community testing sites are asymptomatic.
Right. Okay, I'm done. Thank you.
Thank you, Supervisor Adam. Dr. Duranoso, please continue.
The health equity metric tier progression. So counties with different current status tier, we are in the red, the red substantial tier. For us to be able to move to the moderate, our lowest bottom quartile, again, needs to be less than the 5.2%. There is an accelerated progression possible for counties with current tier status. Again, we are in the red. If we meet for 2 weeks test positivity, both countywide and in the bottom quartile of HPI among tracts in our county, which is less than 2%, and we may progress even though our case rate is higher than 4. So this is a accelerated pathway for us to be able to move forward, even though our case rate is high due to our low testing positivity. And I also will be spending next Tuesday's presentation going over in detail the quartile in Santa Barbara County and what it means to us in terms of census tracts, in terms of strategies and areas. Briefly, Healthy Places Index indicators. They are 8 indicators going through economics, education, transportation, social, neighborhood, housing, clean environment, and healthcare access. And Healthy Places Index is a public accessible database that one can Google and be specific for Santa Barbara County and can take a look at where are the quartiles in our county. The state is working on a health equity playbook for communities. And so the immediate COVID-19 response strategies that we can undertake is around testing, contact tracing, isolation support, and worker protections. And Santa Barbara County, we have been doing all of the strategies listed in the immediate COVID-19 response. Addressing health equity in Santa Barbara County. So given that back in March, we saw early data of cases and progressing to early accounts of hospitalizations affecting primarily in North County among the Latino population, we were worried because we did not know much about the demographics of the cases as well as the hospitalizations. Building on the partnerships that we have established pre-COVID times with UCSB, with MyCOP, with CAUSE, in terms of addressing health disparities in our county, we came forth and we asked, our public health need was, how do we effectively prevent the increase in cases? How do we prevent the hospitalizations? And how do we prevent the deaths in the Latinx community members? And that was the genesis for forming the Latinx and Indigenous Migrant COVID-19 Response Task Force. And I have asked Dr. Melissa Smith to be with us to present in detail the work of the task force.
Dr. Smith, welcome, and thank you for your work on this very important element of our COVID response. Welcome.
Thank you so much.
Thank you. Thanks again, Chair Hart and members of the board. It's a pleasure to be with you. I am Director of Health Equity Initiatives at UC Santa Barbara and the Interim Coordinator of the Latinx and Indigenous Migrant COVID-19 Response Task Force. I also had the pleasure of serving as Chair of the Expert Healthcare Panel for the RISE Guide to Reopening Santa Barbara County. I'm a family medicine physician and have had a part-time clinical role in the health department clinic in Santa Maria, caring for patients, most of whom are farm workers who are indigenous migrant women from Oaxaca, Mexico. The COVID-19 pandemic has made it clear that the Latinx and indigenous migrant communities and their families are challenged by unfavorable social determinants of health. Social determinants of health are the conditions in the environment in which people are born, live, work, learn, and play that affect a wide range of health, functioning, and quality of life outcomes and risks. High-density housing, crowded transportation, lack of access to hand washing at work or access to health care, as well as language barriers, are all examples of social determinants of health that disproportionately impact this population. Unfavorable social determinants of health are compounded by inequities due to race and ethnicity, socioeconomic and migration status, gender, and sexual orientation. These inequities contribute to higher rates of underlying conditions, chronic diseases which increase people's risk of COVID-19 and related complications, as well as higher rates of mental wellness concerns. Because many of these community members are essential workers, they are on the front line and cannot shelter in place. Farm workers, hospital cleaning staff, and service industry workers, therefore, have greater exposure to the coronavirus. It's important to note that on a national level, Black and Pan-Asian Islander communities are also disproportionately impacted by the pandemic. We are working to understand what the data is for these communities in Santa Barbara County and to support efforts to address these inequities. There is tremendous power and synergy in the county-wide collaboration of the task force. We have 93 cross-sectoral partners, including community-based organizations, the Santa Barbara County Public Health Department and Department of Behavioral Wellness, UC Santa Barbara, health service providers, elected officials, funders, and community members. Cross-sectoral collaboration is essential due to the multiple needs of these communities and the diverse resources and capacity as well as expertise of partners who can respond in a coordinated manner. Our task force partners develop and share educational resources, provide direct services, collaborate on outreach efforts, develop innovative programs, and participate in discussions to inform policy change to address community priorities, particularly those focused on the needs of farm workers and their families. Because of the many barriers faced by these communities, it is critical that trusted community partners lead outreach efforts in order to be effective. Our task force efforts are focused on centering community voice and leadership. Community capacity building creates robust, thriving communities and promotes sustainable, participatory processes that are essential to improving community health and well-being. Such an approach creates a foundation for achieving health equity. The bi-monthly task force meetings include vibrant community participation with 60 to 70 participants contributing to our discussion. Simultaneous translation in Spanish ensures that community voices are heard and that we create an inclusive space for dialogue. Our 3 working groups meet on a bi-monthly basis to foster deep and sustained cross-sectoral collaboration and problem-solving in partnership with communities. The Farm Worker Working Group addresses priorities through community outreach, increasing access to resources, and promoting civic engagement and advocacy. The Mental Health and Wellness Working Group provides up-to-date information and resources and facilitates processes that foster support, social connection, empathy, and hope. Their subcommittee efforts are focused on emergency safety planning, youth-teen support and resources, and community outreach, education, and messaging. Finally, the Lompoc Prison Task Force supports the health and well-being of inmates as well as their families. I'd like to highlight some of the accomplishments of our task force. Our partners have provided public health education and multimedia outreach in Spanish and multiple Indigenous languages. Information about COVID-19 prevention, testing, and health services has been provided in flyers and multilingual videos, as well as PSAs. This has been shared via radio, television, text, social messages, social media, websites, and email blasts, as well as through the trusted person-to-person networks of our task force partners. Details about these resources and our partners are noted on this slide. The Mental Health and Wellness Working Group has created a safety plan to support families who may be impacted by COVID-19, as well as a resource magnet and a booklet focused on youth mental health. Our partners have led outreach efforts to communities and farms with resources such as public health information in English, Spanish, and Mixteco, as well as face coverings and hand sanitizers. Our best estimates to date on these numbers include outreach to 21 small farms and distribution of 20,095 face coverings and 1,300 COVID-19 prevention kits. According to Naomi Velasquez, our colleague from the Community Health Centers of the Central Coast, for many of the community members that they encountered, this was the first time they had received any education, outreach, or materials. I'd like to give special thanks to Noemi's team, who included colleagues from the Promotoras Network of Santa Barbara County's Education Office, Dignity Health, and the Food Bank. And I'd also like to thank our other task force partners who are noted on this slide for their outreach work. Our efforts have involved the collaborative development and promotion of public health department policy and COVID-19 program initiatives, including free access to COVID-related care through the public health department, free COVID-19 testing throughout Santa Barbara County, health officer orders, mental health support groups and programs, and the Housing for the Harvest program. We've developed a strong collaboration with a student and faculty team based in the UCSB Center for Publicly Engaged Research. This team has contributed to the efforts of the task force in many important ways. The task force model has been replicated in Ventura County and is now emerging in San Luis Obispo County. Our partners have also led successful efforts to protect the health and well-being of inmates at the Lompoc Prison. Regarding our future plans, our efforts will cement a foundation for future collaboration and rapid response efforts to address new challenges that might impact the Latinx and Indigenous migrant communities. Our cross-sectoral collaboration is an essential and sustainable strategy for achieving health equity in our county. While our immediate efforts have focused on the pressing needs of the Latinx and Indigenous migrant communities as they confront the pandemic, our task force is committed to working with other community organizations to contribute to building a broader county-wide health equity collaborative effort to also include Black, Pan-Asian, LGBTQ, and other communities. We are creating a model for promoting health equity aligned with the health equity metrics provided by the California Department of Public Health that Dr. Do Reynoso just shared with us. And finally, we're planning town hall dialogues with sector leaders, including agriculture, healthcare, the service industry, among others. I'd like to give special thanks to the Board of Supervisors for your important leadership during the pandemic, as well as your support of the task force efforts. And I'd also like to thank all of the participants in the task force, as well as the 93 organizational partners that are listed on the final 2 slides. Thank you so much.
Dr. Smith, I want to thank you on behalf of the board and the whole county for your leadership on this task force and the efforts to promote health equity. As you described, this really is a model. This is exactly what the state's looking for us as counties in partnership with the state to reach out to communities that are disadvantaged and need additional information and assistance. And the collaboration with all these community organizations amplifies that message, and as you said, in many cases gets information for the first time into the hands of people who need that and need to understand what they can do to be safe. So we really appreciate your work. This is an extraordinary effort. Supervisor Hartman?
Yes, I want to echo that sentiment. COVID shows us that we're all in this together. We can't get out of whatever tier we're in until we raise the people in the lowest quartile up. And we had a head start in Santa Barbara County with your efforts. And this is the first time I've heard about it, read a little snippets here and there, but the first time I've gotten to see the range of activities that you're involved in. If there is anything I can do personally or in my role as supervisor to be part of this, I am very laudatory of your efforts, and this is just incredible. It's not easy to reach many of these populations, and you've found and are creating a structure so that we have easy access and communication, in the future, and that is it's really something to congratulate you on, and thank you so much.
Thank you.
Supervisor Williams?
Well, this mission is crucial. While I agree that we have a shared destiny, unfortunately, COVID, like many other health problems, illustrate that we may be in the same storm, but we have different sized boats and are disproportionately affected by that storm. So my question is, I've done a lot of grassroots outreach. It's hard to reach a lot of people. I want to understand, where are those videos and PSAs airing? What methods of communication, printed communication, are we using? And where are areas that you feel that we need to make continued progress in reaching?
Thank you for that question and for your metaphor of the different size boats. I think that for somebody who provides care directly to folks in this community, I think that's very clear to me in many ways. In terms of where the media outreach has been done, or where the videos have been shared, as I mentioned briefly, through various television channels, radio stations, regular blasts. We have partners. There's one group called Mi Vida, Mi Voz, which is a wonderful organization that's based here in Santa Barbara that has been doing incredible media outreach and providing information and resources and videos to this population in South County, and has expanded now into North County. And then the videos are also shared on our publicly shared drive that we share with all of the task force participants. So that means if we have 93 organizations, we have well over 200 individual participants. All of those individuals have also been sharing the videos and the flyers that we put out throughout their networks. So you can just imagine the multiplier effect when you have that many individuals who are using their networks. I don't know whether Dr. Do Reynoso wants to add anything about that.
No, it's just that I think what has astounded me is the community members using social media, their personal Facebook, Twitter, to amplify the PSAs that we are releasing. And what I've heard is that the PSAs that we created may have originated from the county comms team, but the community members from early on, I remember in April when we were all worried about the spring break and Easter, and being able to articulate the dangers of gathering and how to be safe. We developed that PSA, and quickly our partners were able to seize that and translate it into a very culturally and linguistically appropriate manner and amplified it throughout their social networks, and it took off.
Yeah, and just to complement what you're saying, for example, if there's a flyer that's been produced about COVID-19 resources, partners who speak different indigenous languages have made a message in different languages referring to the flyer and then shared those through their social media networks. And we are actually starting to track and able to track some of that, some of the impact through the social media. So that's something that we hope to be able to provide in the future, that kind of data. But it's been quite powerful.
Great, and then I just want to take the opportunity, to highlight one of the causational factors, as you have discovered, and that it is a solvable problem. It takes time to solve the problem, but more than time, it takes political will. I mean, in many aspects of health, it's dangerous to be poor. If you look at everything from nutrition to opportunities for exercise to other things, those are hard to change. But in COVID, the biggest factor seems to be housing. That is possible to be changed. And I think all of us have to think about a little bit about our own community's trepidation or antipathy towards housing, and how that is obviously presenting dangers as people live in fairly high density for people, meaning a lot of people in a house, not necessarily a kind of home that you would think is high density. Often these are single family homes just with 15 residents. And while some people do this out of choice, it's obviously in many cases an economic driven question, as people with multiple different families living in the same single family home in communities throughout our county. So I hope it causes us to have a little more political will when it comes to housing.
Well, thank you again for your presentation. It's really inspiring, and it is great infrastructure that you have created with the Department of Public Health to serve us in many ways going forward, but it's particularly crucial right now during the pandemic. And I want to thank Dr. Del Reynoso for her support and leadership and encouragement of this effort. You were right there from the very, very first beginning idea of this, and I think it has served our county very well, so thank you.
Thank you. Thank you. The last portion of my presentation is an update on school waivers. And we have currently 26 schools approved to open K through 6. Since last Tuesday, we have not received additional waivers from CDPH. CDPH is evaluating Carpinteria Unified Elementary School, Ballard Elementary School, and Santa Barbara Middle School. And we are working with Children's Montessori School in Lompoc for their process. And that concludes my presentation this morning.
Thank you, Dr. Del Reynoso. Are there questions from board members? Comments? I know we have public comment, so let's go to public comment.
Chair Hart and members of the board, we have 2 requests to speak on this item, and we will go first to Gloria Soto to be followed by Naira Pacheco.
Councilmember Soto, welcome.
Good morning, Chair Hart and members of the board. My name is Gloria Soto, and I am a councilwoman for the city of Santa Maria. I am calling today to share with you a little bit about the Latinx and Indigenous Migrant COVID-19 Response Task Force. COVID-19 has hit our communities in a really tough way, and more so in the city of Santa Maria, where we're seeing the highest number of COVID cases within our community. And thanks to this task force, one of the things that we've been able to see is the fact of the cross-sectoral partners that have really come together to tackle the barriers that a lot of our families face when seeking care, when seeking access to programs and services to ensure that they and their families are safe and healthy. And so the thing that has proven to be incredibly helpful has been the dialogue between Dr. Van De Reynoso, our Director of Santa Barbara County Public Health, and all of the community benefit organizations that come together to once again share concerns, updates, resources, and talk and think through strategies to help address this evolving pandemic. And so I am just calling to share my appreciation for public health being a part of this task force and really helping us tackle COVID-19 here in our communities, especially in the city of Santa Maria. And it's been fascinating to see, again, all of the community partner organizations come together and strategize as to how we can better support our residents in our communities. Thank you.
Thank you, Councilmember Soto, and thank you for your work on the task force and your leadership in Santa Maria.
We will now go to Naira Pacheco, who is our final speaker.
Hello, good morning. My name is Naira Pacheco Guzman. I'm the Language Justice Associate for the Latinx and Indigenous Migrant COVID Response Task Force that was formed early at the onset of the pandemic back in March, and has since grown and developed to host a wide array of partners that include different nonprofits, community-based organizations, public agencies, and certain government offices as well. And so at this point, we have 195 participants on our contact list and 102 partners that are formally part of the task force and receive updates. And we meet every other Friday to have the Public Health Department director share report backs and updates to the community that are most relevant specifically to the populations that we are serving. And then we also have a time for community organizations to share updates, as well as our space for our 3 work groups to share about the work and resources that they are providing. And we most recently conducted a survey around the function of our language justice framework and services that we provide for the members of the task force, as well as the sharing of community resources through our online Google Drive. We wanted to conduct this assessment, this survey, to see how useful this was for our partners. And one of the main things that we want to share is that when we asked folks what was the main reason that folks tune into these meetings, at least our expectation was that people tune in to hear the latest information from the Public Health Department. And that came at a close second at 25% of our participants reporting that was their reason. but the majority of respondents for this survey actually shared that they tune in to find ways to connect and collaborate with other partners in facing COVID-19. And this was 42.9% of our task force members who shared this. So all of that to say that it really emphasizes, that highlights the importance of having shared spaces in which all of the resources and efforts that are being created by our organizations and agencies on the ground, that there is actually a space for them to work together and collaborate and not recreate the wheel. So I'm grateful for all of the support that the county has provided us and continues to provide, especially in making sure that we can create these organizing and coordinating spaces with language justice integration so that Spanish-speaking community members and organizers can be part of the work. And in the near future, we will be incorporating Indigenous languages so that organizers from our Indigenous communities can also drive the work that is happening and not just be serviced by it. So thank you very much, and we hope to continue providing more relevant updates from our task force in the future.
Thank you, Ms. Pacheco, and thank you for your work on the task force as well. Are there other public commenters?
That was our final speaker.
Okay, thank you. The matter's back to the board. Any comments or questions remaining? Okay, well, thank you very much, everyone, for the presentation. This is really helpful and illuminating, and I know the public will really appreciate hearing this information directly from you too. Is there a motion to accept this report?
So moved.
Second?
Motion's been made and seconded. Any discussion? Madam Clerk, could you please call the roll?
Mr. Williams?
Aye.
Ms. Hartman?
Aye.
Mr. Adam?
Aye.
Mr. Lavanino?
Aye.
Chair Hart?
Aye.
Motion passes unanimously.
We'll now take a 10-minute break before we go to Department Item number 3.